Our staff really feels that they can point to our systems and recognize the places where they made a contribution that made a difference. And by distributing that and by capitalizing on all the expertise that builds up in our group, no one individual is overburdened by it. Our practice documentation tool is a shingle. Each visit has its own sheet of paper and they lay like shingles on a roof in the chart. This is actually the visit summary, something that we give to the patient that tells her what she needs to pay attention to. Down at the bottom here is actually a set of orders for my staff, and the patients really love it. We have people who tape these up on their refrigerators. We recognize that we had to make sure that those tools worked efficiently for us as providers, efficiently for our staff, and that they also provide an efficient means of gathering the data that we needed to understand how well we were doing.
When we first started this, I kept writing everything down on a piece of paper, and sometimes I wouldn't always say it the same way because I got tired and it was 4 o'clock on a Friday afternoon, so there was no standardization of the education. So we put all our information like this, and this is for kids. We have another one for adults, and this is all the information they want. This is what really makes the outcomes work. This is the patients doing all the work, really. It's just us giving them the tools.
Suddenly there are all these quality indicators that you can measure any way you want to, primarily for practice improvement. I spent one weekend using the program to search for all patients with any kind of cardiac diagnosis who weren't on aspirin, and boom, 4 pages of names showed up. So I called them up, and on a Saturday I said, "This is your doctor, would you start taking aspirin?" They said, "Sure." And at the end of a couple of hours of planning like that, I said, "My gosh, I'm probably one of the only practices in America who can unequivocally say that every patient of mine who needs to be on aspirin is on aspirin." And that was very electrifying.
You need to somehow, when you do a quality improvement project, be able to measure that what you do made a difference. You need to move that needle. We had, over the last 5 years, a big drop in our inpatient asthma admissions and a drop in our length of stay below the national average. And those outcomes are really important to the institution, which helps fund our program.
We post measurement, unblinded measurement, both comparative with other clinics and individual provider measurement on different things in our break room. And people can see that. And it motivates a medical assistant who worked with a physician provider or a nurse practitioner provider to think, okay, how can I get my provider's numbers better? What am I doing that might help? By doing that, you bring in not just the professional energies and competition of the providers, but you really distribute the professional satisfaction around to everybody else in the group. And once everybody's on board, the energy that produces the results makes it a lot easier than you'd expect it to be when you start out.
One of the new interns, I was telling about the asthma program. He was going to go see a 10-year-old, and he said, "Tori, I don't know much about asthma." I said, "Don't worry, this will work. Here's the program, here's the questions you need to ask," and went through it all. As he was walking into the room, and I was sort of walking by, I heard the 10-year-old say, "Hi, Doc, you're one of the new ones. Let me tell you about asthma." And seriously, this is true. He takes out of his little fanny pack that we give him. He goes, "This is my reliever, and this is my controller, and here's my school plan that you need to fill out." And here was the patient educating one of our new learners, and to me, it's working.
People aren't going to want to go to the doctor's office very more unless they're sure you're looking up more information on the net for them, and you're using tools that put together information in interesting ways, guarantees them safety of taking their medications, and can be brought, and that information can be taken any place in the world they may want to travel to. So they can get started.
I am gratified by my front office staff showing pride in the quality of the work that they do, because that suggests that the culture is one that will generate the kind of energy that is necessary for that quality improvement work to continue.
As physicians, we're probably all overachievers. We want to do too much. So I think we need to sometimes think smaller.
None of us got into medicine because we wanted to be able to see 35 patients a day or 30 patients a day and make a great living. We got into medicine because we wanted to make a difference in people's lives. And we've gone from having a sense that we did that to having evidence that we did that. We took a paper-based system and turned it into a really effective quality improvement system. The most important thing that I did, that we did, was to stop making excuses. to stop thinking about why it is that we can't do it, what stands in the way, and figuring out what we could do with the resources that we had. So just stop making excuses.